Okay, so I think we're ready to make a start, and a very warm welcome to everyone who's joining us today, and a very warm welcome to our speaker, Dr. Nutmeg Hallett. Thank you so much for joining us today. Dr. Hallett is a mental health nurse lecturer in the School of Nursing. Her background is in forensic nursing. And today's talk will be on coercion, restriction, and restoration in mental health. As with all, we'll follow the usual format. So Dr. Hallett will speak for approximately 40 minutes. Is that correct, Nutmeg?
That's right, 40. Yeah.
Excellent. And then we'll take questions. So feel free to post your questions on using the Q&A function, and I'll be able to pick this up. We'll take questions at the end. Nutmeg, over to you. And then once again, thank you so much for joining us today.
Thanks, Maria. So yes, as Maria says, my name's Dr. Nutmeg Hallett, and I'm going to be talking about coercion, restriction and restoration in mental health. And I appreciate they're all really big topics, so there's a lot to fit in. So I will make a start. So just to tell you a little bit more about myself, Maria's introduced me. So yes, I am a mental health nurse. I did my training here at the University of Birmingham. And after qualifying, I went to work at Rayside, which is a medium secure unit. I was a ward nurse there, absolutely loved it, really enjoyed the interactions I had with patients, but felt a bit stuck after a few years. I couldn't see a clear career progression. I didn't want to stay on the wards and go into ward management. I didn't particularly want to go into the community. And then I was lucky enough to get the opportunity to do a funded PhD at St Andrew's Healthcare in Northampton, which is the middle picture on the screen, one of their amazing properties. So I was lucky enough to be there for 3 years based on those grounds, doing my PhD. And then after that, I got a lecturer's post here at the University of Birmingham, and that's where we are now. Oops, sorry. So sorry about that. So a really good place to start is thinking about what is a mental health nurse. It seems really obvious, but actually it's not. Mental health nursing is surprisingly hard to define. When I was a nurse working on the wards, I would come home from every shift absolutely exhausted, being busy all day. But then I'd try and think about what I did, and I'd find it really hard to articulate what I was actually doing. And it's not just me. In discussions with the NMC when creating their new nursing education standards, a whole room full of mental health nurse academics really struggled to explain mental health nursing, at least in a way that was quantifiable, which is what the NMC was looking for. General nurses, they have a whole range of skills that need to be competent at, and which can be measured. It's fairly easy to assess if you can take a blood pressure or insert a cannula. It's not so easy to assess how good you are at developing a therapeutic relationship. Actually, colleagues in Australia this year have tried to define what a mental health nurse is, or what the role of a mental health nurse is. And they've identified that mental health nurses are psychotherapists, they're consumer advocates, they're physical health therapists, psychopharmacological therapists, relationship-focused therapists, and aggression management therapists. And if you look at those roles, some of them are roles in themselves, obviously psychotherapist, consumer advocate. Actually, mental health nurses need to be fairly good at all of these. So really, mental health nurses are jack of all trades, master of none. And actually, there's a similar lack of clarity in nursing research. Nurses are very good at navel gazing. A lot of the research conducted by nurses is about nurses. So looking at things like burnout and resilience, for example. This is important, really important, because without a fully functioning nursing workforce, services struggle. But actually, for me, the focus of nursing research should be the recipients of nursing care. And as an aside, I don't really want to weigh in on the debate on what term to use. Jeff Dickens, who's a professor of mental health nursing, did some research with people in secure mental health settings, and the term patient was in fact preferred by 42% of respondents, compared with only 20% preferring client and 17% preferring service user. So I do understand that labels can be stigmatizing and disempowering, but if I use the term patient, Jeff's research is partly the reason why. So for the rest of my presentation, I'm going to take you on my research journey which started at violence prevention through coercion and to restoration. In some ways, it's been quite difficult for me to articulate this journey because I look back to where I began and I feel that it's not entirely compatible with where I am now. As a mental health nurse, and thinking back to the roles of a nurse that I just listed, a big part of the job is preventing and managing aggression. So when I entered the world of research, this felt like a really important area to explore and focus on. The public health model of violence prevention was integral to my research, and this looks at the different levels of prevention, beginning with primary prevention at the bottom of the pyramid because it's the most activities that go on. And these are the things that prevent or reduce the likelihood that violent behaviour will be initiated. So it's things like staff training, patient training, planned activities and boredom relief, good staff-patient communication and care planning, to name a few. After that, there's secondary prevention, and those are the things that either prevent or reduce imminent violence. And here there's less to work with. De-escalation and PRN are two of the key secondary prevention activities. And then finally, there's the activities that prevent or reduce the physical and psychological harm of violence whilst it's occurring and after the event. And so this is things like restrictive interventions, so restraint, compulsory intramuscular medication, seclusion, but also things like post-incident debriefing and review of the incident. So my PhD explored primary and secondary prevention, looking at how de-escalation was used by staff and in care planning, as well as exploring staff and patient perceptions of the prevention climate of the ward. So that means how wards are perceived as conducive to primary and secondary prevention. And going back to the model of the public health model, I think it's really important. It's well used. Most people know it now, I think. But actually, for me, it's missing an important element. So I think of it much more as a cyclical model. If you think of prevention as a pyramid, then it ends with the tertiary activities, but it doesn't end there. Post-incident debriefing and review of incidents should feed into all primary prevention activities. It should feed into care planning, which in turn will feed into the secondary measures that really work with individuals. So for me, thinking about it cyclically is a more helpful way of thinking about prevention. If I were to summarise my PhD in one sentence, it would be as simple as, be nice to people and they won't hit you. But actually, it's this that I now find slightly problematic, because yes, it's possible to put measures in place to prevent or reduce violence, but actually for me, that's addressing a symptom rather than the cause. So what are the causes of violence? The model that I based my PhD on was this one, which at the time was the only model of inpatient aggression. So this was from Nyman and colleagues, which he created in 1999. Now we have safe wards, which gives a more in-depth but quite complex model. So I still find Nyman's model quite helpful. It breaks down the stresses that patients experience into ward, patient and staff variables. The problem I have with this model is that it's quite a narrow view of aggression. It doesn't look at the wider context, and particularly for me, coercion and trauma are missing. I find it much more helpful to think about an experiential cycle of trauma, symptoms, coercion, aggression, and restrictive interventions. But to understand this cycle, it's important to understand each element. We know that people in contact with mental health services have higher rates of trauma history than the general population. Rates of abuse in both child and adulthood are higher for people in contact with mental health services. There's a growing body of evidence looking at the link between adverse childhood experiences and physical and mental ill health. So adverse childhood experiences, or ACEs, are events that are potentially traumatic and that occur in childhood, so under the age of 18. They include experiencing or witnessing violence, abuse or neglect, having a family member attempt or die by suicide, and growing up in a household with substance abuse, mental health problems or instability. ACEs have been shown to be linked to increased risks of depression, suicide attempts and psychosis, and exposure to childhood trauma is likely to be associated with heightened dissociation in severe mental illness. Dissociation can be defined as a disruption of and/or discontinuity in the normal integration of consciousness, memory, identity, emotion, perception, body representation, motor control and behaviour. While dissociative experiences are common in the immediate aftermath of trauma, they can continue into the long term and may be misinterpreted as a psychiatric symptom. For example, voice hearing, which until relatively recently was considered nothing more than a symptom of psychiatric illness, is increasingly viewed not just as a secondary feature of trauma-related disorders, but as being reflective of a core process or phenomenon that is a fundamental response to trauma. So we can conclude that trauma plays a significant role in the development of symptoms. It's therefore reasonable to assume that many of the people who are mental health inpatients are likely to have some degree of trauma history. If people have trauma and the trauma leads to symptoms, the symptoms are what leads to people being admitted as inpatients. And as some fantastic colleagues at UCLan have said, so Mick McEwen, he says, unlike other healthcare contexts, mental health services are unique in legally mandating compulsion and coercion. And so I'm not passing judgment on the legislation that governs mental health services, but due to the potential for coercion and perceived coercion, it's especially important to explore these experiences from the patient's perspective. Involuntary admissions are, by their very nature, coercive. People often describe feeling coerced into admission to hospital, even when they're there voluntarily. Similarly, people often feel coerced into taking medication. As Tillman Steinert asks, why should a person not have the right to refuse treatment and the right to remain ill? He continues, nobody would be forced to accept a diabetes diet, drugs for increased blood pressure, or chemotherapy or surgery for cancer, even if there was a considerable risk of deterioration of health or even death. Then why should a person with schizophrenia or mania be forced to take medication against his or her will? Again, these are big debates that are far beyond the scope of this seminar. But as a nurse, it's important to be aware of the feelings that their actions can create in people. If you understand this, then it's hardly surprising that some people resort to violence. We know that violence is most common in the first 72 hours of admission. It's likely this is in part, at least, due to the experiences of coercion that people have had in arriving at hospital. Restrictive interventions are frequently used in response to inpatient violence. The restrictive interventions being restraint, seclusion, and rapid tranquilization. As stated in NICE guidelines, they shouldn't be used to punish, inflict pain, suffering, or humiliation, or to establish dominance. At this point, I think it's important to acknowledge that there are times when patients are failed by the people and systems that are meant to protect them. For example, as identified by Panorama at Winterbourne House and more recently Wilton Hall. These scandals highlight what I think for most healthcare professionals are shocking abuses of power, but they're not the norm. For many healthcare staff, and especially nurses, restrictive interventions are viewed as necessary but problematic. Nurses often feel conflicted, having to balance ethical and safety values. A key part of the inpatient nursing role is maintaining safety. If someone's behaving in a way that may affect the safety of themselves or those around them, nurses have to make very quick decisions and often have a very limited range of options. Although restrictive interventions are meant to be a last resort, nurses often feel that they're the only resort. To give you an idea of the scope of restrictive intervention use, in February 2020, around 1,900 people experienced almost 10,000 restrictive interventions in English mental health services alone. So restrictive interventions, for the most part, are used in a way that comes from a good place, with no intention on the part of the nursing staff to punish, inflict pain, suffering, or humiliation, or to establish dominance. Despite this, patients' experiences of restrictive interventions are often linked with feelings of being punished or humiliated and feeling powerless. On top of that, physical and psychological harm are regularly unintended consequences of restricted interventions. The most common cause of staff injuries in mental health settings is involvement in the physical restraint of patients. and physical injuries are also common for the patients who are restrained. But it's the psychological harm, especially to patients, that can be more long-lasting. Many of the traumatic experiences that people have as inpatients are related to restrictive interventions. Patients frequently report retraumatisation as a consequence of restrictive practices, and particularly physical restraint, with the experiences bringing back memories of previous abuse. The negative experiences of hospitalisation may be compounded by issues related to ethnicity and gender. Black and minority ethnic communities experience inequalities in mental health, including disproportionate experiences of the factors that are linked to poor mental health, poorer outcomes from mental health treatments and interventions, and poorer relationships with mental health professionals. Patients from Black and minority ethnic communities may experience disproportionately high levels of coercion. We also know the prevalence of childhood physical and sexual abuse in women is higher than that of men in mental health services. Yet around 1 in 5 women admitted to mental health facilities are physically restrained. And in some UK trusts, women are substantially more likely to be restrained than men. So what can we do about all of this? One option, maybe we need radical change. The United Nations has been critical of the use of compulsory measures in mental health care since the UN Convention on the Rights of People with Disabilities in 2006. World Health Organization guidance on community mental health services, published this year, asks for eliminating the use of coercive practices, such as forced admission and forced treatment, as well as manual physical or chemical restraint and seclusion, and tackling power imbalances that exist between health staff and people using the services. So colleagues in Holland, Dirk Richter and others, argue that there's no justification to utilise compulsory measures against people who do not regard themselves as mentally ill, and therefore that mental health care should only be applied to people who do regard themselves as mentally ill. While I think this is a laudable goal for mental health care, it's unrealistic, in the short term at least. So what can we do? There's been a massive push towards interventions and programmes to reduce the use of restrictive interventions, with some really positive results. 2 widely used programmes are the 6 core strategies developed in the US and focusing on top-down approaches such as workforce development and leadership in organisational culture change. And safe wards, focusing on nursing interventions that reduce both conflict, so patient aggression, for example, and containment, which includes but isn't limited to restrictive interventions. So where does this all fit in the experiential cycle of trauma, coercion and restriction? And what can we do to break the cycle? While there's nothing that nurses can do to retrospectively remove historical trauma, there's much they can do to reduce the harm of it. Services are shifting towards being trauma-informed, which with staff now being expected to work within a trauma-informed framework. What this actually means is not fully defined, but the fact that trauma is now being acknowledged is an important culture shift. Nurses have an important role to play in symptom management, although this is often medication focused. However, the medication debate is another really big topic that is way beyond the scope of this seminar, so I'm going to leave it there. There's a lot that healthcare staff can do to reduce coercion, but what can't be changed, at least until there's an almost revolutionary overhaul of services, is the need for involuntary admissions, nor the use of restrictive interventions. Again, there's a lot that healthcare staff can do to reduce aggression. The safe ward interventions, for example, provide a comprehensive list of primary and secondary prevention activities for staff and patients, including things like developing clear mutual expectations in relation to ward rules and identifying calm down methods for when patients are becoming upset, agitated or aggressive. But these aren't always successful. At the moment, restrictive interventions feel almost inevitable. Their use continues despite all the programmes aimed at reducing them. One area that's received relatively little attention, despite being a priority for patients, is breaking the link between restrictive interventions and trauma. One way of doing this is with post-incident support. It's necessary to help patients process the incident to reduce the risk of trauma. It can be helpful, especially when used to facilitate discussions between the people involved, and may reduce incidents of conflict and its related containment. It's not, however, clear how this should be structured. NICE found little evidence of how post-incident support should be delivered, at least in 2015, when the most recent guidelines of inpatient violence were developed. There's been some research conducted since then, but there's still a paucity of good quality evidence to tell us what is most effective in terms of post-incident support. What the evidence does tell us is that it's important to reduce the emotional impact of restrictive interventions. And looking at what works is particularly important in light of what we know about psychological debriefing, with a Cochrane review finding that there's actually little evidence of the benefits of single session debriefing after any trauma, and that it may actually be harmful. And a subsequent Cochrane review of multi-session psychological debriefing concluded that it shouldn't be routinely offered to people after experiencing trauma. So if, as NICE advises, all patients subjected to potentially traumatic restrictive interventions are to be offered post-incident support, a framework should be used that is appropriate to everyone. And I got a bit stuck here in my thinking until I started thinking outside of the box. Somehow, I got thinking about the Truth and Reconciliation Commission in South Africa. So this commission investigated human rights abuses committed under apartheid, exploring the circumstances, factors, and context of such abuses. They gave victims the opportunity to tell their stories and drafted reparations policies. Despite some vocal opponents on both sides, they were very successful and essentially healed a country. They provided a model for building peace and justice, which is still being used today. The Truth and Reconciliation Commission in South Africa was based on principles of restoration. So, what is restoration? Again, there's no agreed definition of what it is. Restorative practices can be described as a social science that studies how to build social capital and achieve social discipline through participatory learning and decision making. And a subset of that is restorative justice, which again can be defined as a process through which parties with a stake in a specific offence collectively resolve how to deal with the aftermath of the offence and its implications for future. And so just to kind of give you a bit of an idea of restorative justice, I'm going to run through a brief history, and I do mean brief here, of restorative justice. So actually it's a relatively recent term for a tradition that goes back to systems of justice in ancient civilizations, which took a restorative rather than a punitive approach to crime. Restoration has actually been the dominant model of criminal justice throughout most of history. A restorative approach was taken by ancient Arab, Greek, and Roman civilizations, even to severe crimes like homicide. Many of the Eastern traditions take a restorative approach. Indian Hindus believe that he who atones is forgiven, and similar messages are seen in Buddhist, Taoist, and Confucian traditions. Aboriginal healing circles have traditionally been used to develop a community consensus on how to repair the harm of an offence. It was only at the end of the Dark Ages that justice systems in Europe shifted to the punishment model now prevalent in Western cultures. Crime was transformed into a matter of felony against the king rather than of wrong done to another person. Interest in restorative justice was rekindled in the West and mainly in America in the 1970s with victim offender rehabilitation programs. A central facet of restorative justice is victims and offenders having the opportunity to meet. The Restorative Justice Council in the UK identifies 6 principles of restorative practices. The primary aim of restorative practice is to address and repair harm, so restoration. Participation in restorative processes must be voluntary and based on informed choice. Restorative processes should be fair and unbiased towards all participants. They aim to ensure the safety of all participants and create a safe space for the expression of feelings and views about harm that's been caused. Restorative processes are non-discriminatory and available to all those affected by conflict and harm, and they should be respectful to the dignity of all participants and those affected by the harm caused. It's quite important to think about who is restored. So for victims, they may have property restored, they may have psychological injury restored. Participation in restorative processes can often give people a sense of security, dignity, feelings of empowerment and harmony based on a feeling that justice has been done. And offenders are restored. They achieve dignity by confronting shame, accepting responsibility and apologising with sincerity. They can have feelings of security and empowerment restored by achieving successes. And finally, communities can be restored. So at a micro level, restorative justice is a bottom-up approach for restoring communities by restoring the social support for victims and offenders. At mid-level, restorative practices can foster community organisation within, for example, schools or neighbourhoods. At a macro level, restorative justice can be seen as the implementation of deliberative democracy, giving citizens the opportunity to be involved in the application of laws or rules. So, where are restorative practices happening now? As I said, Truth and Reconciliation Commissions began in South Africa and are still being used today. At a societal level, at least, these commissions have gone some way to addressing human rights violations, and participation in the testimony and interview processes has been demonstrated to increase survivor empowerment, which suggests that being given the conditions to be heard may be part of the healing process. In criminology, restorative justice provides opportunities to bring victims and offenders together. Victim psychological outcomes and satisfaction are consistently higher for participants of restorative processes when compared with traditional justice system processes, as is offender satisfaction. And restorative processes appear to cause a modest but highly cost-effective reduction in recidivism after crime, and compliance with restitution agreements is significantly more likely for offenders participating in restorative processes. Restorative practices have been used in schools in a variety of ways, including for conflict resolution, response to incidents, conferencing and whole school programmes. Conferencing, which focuses on specific incidents and individuals, has demonstrated good levels of engagement with the process and satisfaction with the experience. And introducing restorative practices has been shown to improve overall school discipline, increase attendance and reduce absenteeism, while creating a more positive school climate and improving academic outcomes. So as you can see, the benefits of restorative practices are far-reaching. The obvious home of restorative justice in mental health is where criminal justice meets mental health care. And so that's in secure services, sometimes known as forensic services. And in case you don't know, people in secure services can come from police custody, the courts or prison. So if they were unwell when they committed a crime, they may be held under the Mental Health Act, or they may become unwell whilst in prison and be moved into secure services. Some people in secure services haven't committed any crime, but are not able to be managed in acute mental health services. In fact, one of the first mental health services to use restorative justice in the UK was Broadmoor Hospital, which, in case you don't know, is one of 3 high secure mental health hospitals in England. And they introduced restorative justice to address a problem. When a patient assaulted another patient or a member of staff, if the dispute couldn't be resolved, either the patient or the staff member would be moved to keep them apart. Unfortunately, they were ending up with so many patients and staff that could not be on the same wards. They didn't have enough wards to separate them all and needed a more permanent solution. And that's when they introduced restorative justice, taking the approach from criminal justice of bringing offenders, in this case patients, together with victims, who were either staff or patients, as a way of resolving conflict and moving forward, thus allowing victims and offenders to remain together on a ward. Thinking about violence and coercion within a restorative framework may be difficult, but not impossible. I hope that we can all agree that mental health services, by their very nature, can be coercive. Coercion can lead to conflict, and where there's conflict, there's a risk of harm. Patient violence can cause harm to staff or other patients, and patients may inflict harm upon themselves through self-harm and attempted suicide. There's also increasing evidence that services themselves can cause both retraumatisation and primary trauma, especially with the use of restrictive interventions. But what this all means is there's no clear victim or offender. If you talk to patients, they'll tell you they're the victims of services, of controlling staff, of restrictive interventions. If you talk to staff, they'll tell you they're the victims. Patients are the offenders, and the staff are just doing their jobs when they restrain patients. The difficulty is that they're both right. If you tried to restrain someone the way that you're taught as a mental health nurse in public, say on a night out, you'd probably be arrested. So it's completely reasonable that patients feel they're the victims. However, staff are not only expected, but are often required to use restrictive interventions as their only means of keeping people safe. Now, if you think back to the primary aim of restorative practices, which is to address and repair harm, it seems like the obvious framework with which to address conflict in mental health. Really, I'm surprised that it's only in the past 5 years or so that it's been introduced into mental health services within the UK, and mostly, but not totally, from a restorative justice principle of patient as offender. Because restorative practices in mental health are in their infancy, it's a really exciting time, but there are risks. One of the biggest risks for me is that restoration becomes a bandwagon, a bit like trauma-informed care has. And in fact, I believe that trauma-informed care provides a cautionary tale. Whilst it has the worthy aim of responding to people's needs within the context of their personal trauma histories, it's not well defined nor universally understood, meaning that there's little clarity around what trauma-informed care actually looks like. Services proudly proclaim that they're trauma-informed, but if there isn't universal agreement about what this means, there's no yardstick against which to measure the veracity of such claims. If services are based on fashion rather than evidence, there's a risk that resources are not used effectively or efficiently. There's a danger that the same thing could happen with restoration. The advantage that restoration has is that there's already a vast evidence base for effectiveness away from mental health settings and from which evidence can be drawn. So what next for restorative research? And this is where I am now. There's some big questions that need to be answered. The first being, can it work? From where it's already started to be happening, it seems to be, but we really need to unpick this. One of the big questions also is if staff and patients both see themselves as victims, traditional restorative justice approaches may fail. And so how can this be overcome? We need to think about how we stop restoration becoming coercive. If you remember back to the aims, it has to be voluntary. If NICE guidelines are saying that all patients have to have some sort of debriefing after restrictive interventions, how do we stop restoration becoming a coercive part of the process that they just have to participate in because NICE has said so? We need to think about who can deliver neutral interventions. If it's delivered by staff, will patients feel that they're being unfairly treated? If it's delivered by peer support workers, maybe staff will feel that they're not fairly represented. And finally, what we really need to know is what works for whom and in what circumstances. And so anyone who knows anything about realism will know that is a very realist question. And that's where we're at the moment. We're just arranging funding to be able to do a realist review of restoration as it is in mental health services at the moment, drawing on evidence from other fields and doing primary research around what is actually happening. And so I've put some references up here on the slide, but I'll leave that there. And all I can say is thank you very much for listening.
Wonderful. Thank you so much, Anna. That was such an interesting presentation and really exciting to see your plans for taking this forward, because immediately one of the questions that was in my mind is, has this been evaluated? What is the evidence base behind it? So my understanding is that this is not something that's been evaluated within mental health settings. Is that correct?
Yeah, absolutely. There's been one or two qualitative studies, a bit of case study research, but there's been no real evaluation of efficacy or any of it, which is kind of where we're coming in, that we want to do that before it starts being used without an evidence base for its use.
Exactly. And I've seen very nice, so in your plans for next, what's next, the sort of process evaluation, so for whom, how and why, but were you also thinking further down the line, if we've got enough evidence that it works, for a sort of some work around the implementation of it and how it's being implemented, and sort of fidelity as well around it?
Absolutely. So that's kind of the next step. We need to see how it's working at the moment, and then we can start looking at interventions and, as you say, looking at the fidelity and the acceptability of them. There's lots of things to unpick. So yeah,
absolutely. Okay, so we've got a question, and I think something that you very briefly touched about trauma-informed care, and you should be able to see the question yourself, but I will read it out for the benefit of all the attendees. So you spoke of trauma as if it was the singular or the most significant causal factor for mental illness, and I'm just wondering how much evidence there is and how the very definition of trauma might influence prevalence. A slight concern is that some, if not many, individuals who do not have a history of trauma might be overlooked, or in some cases be forced to construct trauma as encouraged by health professionals. So it makes me wonder if an individual-based care model might be more useful without making assumptions that an individual with mental illness might or might not have experienced trauma.
Absolutely. I think that's a really good question, and it is something that I've thought about, and I thought about bringing in to the presentation, because I do know that it's one of the criticisms of trauma-informed care is that not everyone in mental health services has experienced trauma, and if you view everyone from that lens, potentially you're excluding some people. The other kind of part of that is that not everybody who enters mental health services will experience restrictive interventions. Not everyone will be aggressive and require such interventions. So actually the people that my work refers to is a relatively small subset of the whole population anyway. What I don't know, and I think it'd be really interesting to look at, is actually of the people who become aggressive, or the people who have restrictive interventions, are they more or less likely to have experienced trauma? Because I think, we don't know fully about the causes. We know that trauma can cause mental illness, but obviously there's a whole range of factors that it does cause. And so, trauma is just one. I think the reason it's important to think about in this context is because we know that restrictive interventions can be traumatic. And so, even if somebody's got no trauma history when they come in, if they experience being restrained, that can be traumatic in itself. And so that's where we need to kind of break the chain between what we do and the trauma it can cause. But you're right, not everyone does, and we shouldn't assume that everybody has experienced trauma. It's a good point.
Wonderful. Thank you so much, Nutmeg. And I'd like to encourage our attendees to post in their questions. And in the meantime, can I ask about any plans for involvement of service users in sort of the development, evaluation, implementation of restorative practice interventions?
Yeah, absolutely. So again, that's a really important area. And so in the research that we're looking for funding for at the moment, we've had lots of service user involvement right from the start, so kind of in the development and thinking about what the priorities are, so not just as a kind of tokenistic name on a form, but actually as an integral part of the research team. And as we go forward, when we when we do our realist evaluation, actually a big part of that is the conversations that we have with the people who it's going to affect. And so, yeah, absolutely, people, inpatients, people who've experienced restrictive interventions, but also involving nursing staff and the healthcare staff, because they're both in restoration, everyone's equally important. And so it's not about giving any one side more of a voice than the other. It's actually about bringing everyone together.
Absolutely. And I guess one of the challenges there is sort of the natural power imbalance and sort of managing those power dynamics in those relationships.
Absolutely. And I mean, I think for me, one of the really powerful things about restorative practices is it gives people the opportunity to speak and be heard. So I've spoken to lots of people who have experienced restrictive interventions, and the one thing that I consistently hear is that people are restrained and then nobody ever talks about it again. So this awful big thing has happened to them, and then it's as if it never happened. And so for patients, that's kind of adding to the trauma, because it becomes something that's unspoken. But as a nurse, and you know, I was a nurse, and I think we don't have the tools or the language to know how to address these things. And so I think for nurses, you think, okay, the person's been restrained, they're not being aggressive anymore, so we've done our job and we can just move on to the next thing. And I think having a space where everybody can come together and have the opportunity to say, you know, I found this difficult, or I found this upsetting, I think would be really liberating for both patients and staff.
Yeah. And perhaps looking at the role of this in the person's recovery, ongoing recovery.
Absolutely. I think that's really important as well.
So we've got a couple of questions. One of them says, aware you said you wish to focus on patients in your research, but I wonder if I could ask about staff. Moral injury has received a lot of attention in the pandemic, and clinicians having to make ethically difficult decisions. And it made me think that much of the mental health care can be seen to involve risk of moral injury. And I wonder if you see a connection here with restrictive and coercive practices.
Absolutely. I mean, if you look, you know, there's been quite a bit of research with nurses looking at the ethics behind particularly seclusion and restraint. There's not so much about medication, which is interesting in itself, I think, because for patients that can sometimes be one of the worst elements. But from nursing perspectives, there's what comes out is the conflict that nurses feel between having to maintain safety but having to make ethical decisions, and actually they don't always align. And I think you're right, moral injury is probably a really important topic to look at, particularly in relation to restrictive interventions. I mean, there's very little research around staff characteristics and the relationship with the use of restrictive interventions. There are bits, but there's no conclusive evidence. So, you know, some studies will show that more experienced staff are more likely to use them. Other studies will show less experienced staff. There's no conclusive evidence. And I think unpicking those staff factors, yes, I've said patient, you know, we should focus on patients, but we do need to be able to unpick those staff factors that can lead to overuse of coercive interventions, which we know. I mean, if you look at the differences between trusts, some trusts will report really high levels of restrictive intervention use and other trusts will have hardly any. You can compare wards and they're very different. And some of that will be patient mix, but I think some of that is then culture and nursing staff characteristics and attitudes. So we need to look at that as well.
Yeah, wonderful. We've got one more question, if that's okay. It's great to see that you're planning a realist review. I'm wondering if you have considered middle range theory in relation to restrictive practice, and whether you could suggest any that might enable a level of abstraction to understand restrictive practices better. Often it feels that restrictive practice is as much about staff managing their own fear.
Yeah, Jenny, you're absolutely right. I mean, so much of it is tied up in staff emotion. And so, yes, fear is one thing. But I think, you know, there's other emotion involved as well. We haven't got to the point of middle range theories. I think it's a good point, and we do definitely need to be looking at that, and we need to, you know, look at that level of abstraction so that we can actually understand restricted practices better. So yeah, we're not there yet, but thank you.
Wonderful. I don't think we've got any more questions, and these were great. I'm just going to give our attendees one last chance to post any further questions. But needless to say how important Nutmeg, this work is, and how we all sort of look forward to inviting you back perhaps in a year's time to see where we are up with this.
Hopefully, yeah, absolutely. That's what we want to be.
Yeah. Okay. I don't see any further questions or comments from our attendees. So if that's the case, if nobody has anything else, then perhaps we can draw this to a close and say a very, very big thank you for joining us today. It was so interesting to find out about the work that you do, about the next steps, and also a big thank you to everybody who's attended today. Oh, just to say that the session has been recorded, and we will provide the recording. And the next seminar will be on the 6th of December. We've got Dr. Maria Daberman, and details of this will follow. And we've got a comment from Karen Newbegin. Thanks, Nutmeg. That was a great presentation. So
thanks, Karen. Nice that you're here.
Yes. Wonderful. Okay, well, thank you all. And once again, thank you so much, Nutmeg, for joining us today.
Thank you. Thank you for having me.